Dr. K Sethi. I am Chairman and Managing Director of Delhi Heart and Lung Institute in New Delhi. Today we had a discussion about unstable coronary artery disease in this large gathering of Association of Physicians of India. And a few take-home points that we discussed are as follows. First, the spectrum of presentation of unstable coronary disease is very wide, and it can range from ST elevation infarction, non-ST elevation infarction, and unstable angina to sudden cardiac death, hemodynamic instability, and cardiogenic shock. Key to the diagnosis of unstable coronary disease is good history taking, a proper assessment of not only classical symptoms of ischemia, but also their variants, which we call as angina equivalents, most commonly presentations with difficulty in breathing rather than chest discomfort, especially in elderly, in patients with diabetes, and in females. A diagnosis of unstable angina rather than infarction is becoming less and less common, not because the disease is not occurring more than what it used to be, or it is started to reduce in its prevalence, but because of the availability of high sensitivity troponins, which have increased our ability to detect cardiomyocyte necrosis, which forms the basic definition of myocardial infarction. When we talk about atherosclerotic infarction, it is a formation of a thrombus in a coronary artery superimposed on a ruptured atherosclerotic plaque that results in severe ischemia or distal embolization of a thrombus. If ST segment is elevated in the ECG, it's a STEMI which goes to a different pathway of treatment. If it is not elevated, then we call it a non-ST segment elevation. And most of these unstable coronary syndromes are characterized by these two conditions. The diagnosis of unstable angina is now becoming less and less common. However, we should also remember that troponin testing needs to be done 2 times to rule out a myocardial infarction or rule in a myocardial infarction. One at 0 hour, which is at the time when patient arrives in the emergency room, and then 1 hour after that. And then there are standard sets of values available that must change between the 2 readings to call it a definitely positive test. And it is also an important criteria to remember that at least one of the troponin levels should be above the upper reference limit of a given assay that you are using in your laboratory. Apart from type 1 myocardial infarction, which is thrombotic, there are other causes of elevated troponins which we should not forget, such as tachy or bradyarrhythmias, heart failure, severe hypertension, aortic stenosis, subarachnoid hemorrhage, etc. And other diagnostic conditions that should be kept in mind are myocarditis, Takotsubo disease, aortic dissection, and pulmonary embolism. So one has to keep these things in mind, and then once you make a diagnosis of ST elevation or a non-ST elevation infarction, the patient needs a dual antiplatelet therapy. But these days we emphasize that preloading before a coronary angiogram in non-ST elevation myocardial infarction should not be done with dual antiplatelet therapy. Prasugrel is the preferred antiplatelet agent, but ticagrelor can also be used at the time when the angiogram has been performed and the patient has to undergo coronary angioplasty and stent implantation. Medical therapy would consist of dual antiplatelet therapy combined with beta blockers and large dose statins to reduce LDL levels to less than 55 in the first episode, and if there is a recurrence of the acute coronary syndrome within 2 years, then the targeted level of LDL should be 40 milligrams per deciliter. Dual antiplatelet therapy should be continued for at least 1 year, but the duration can be less or more depending upon our assessment as to what is the bleeding risk of a given case vis-a-vis what are the chances of recurrence of ischemia. Thank you very much.